we're going to start with Dr. Ossie. I asked Dr. Ossie to present this concept of flow-directed lysis for you. If you're not familiar with it, it's something that I think has a lot of value, particularly if you have a DVT or if you are treating DVTs. So he's going to start with the value of calf vein DVT as well as popliteal and the contribution of this new method. It's not new, but it's new probably to you. So Francisco Ossie from São Paulo, Brazil.
Well, thank you again for the opportunity to be here. I just want to ask you to excuse my English because it's not as good as my Portuguese, and if you want, I can give the talk in Portuguese, but I don't think you will understand. So the first picture is showing us that chronic venous insufficiency is not new. People from that time already knew about the problems and the implications of having DVT, of having varicose veins, and all sorts of venous diseases, and what that means to their quality of life. From that time until about 10 or 15 years ago, venous procedures were kind of something that no one would think about or do or pay attention or give any attention for that. But the numbers are here, are out there to not let us forget that for every arterial patient that we have, we will have 9 venous patients coming to our offices. So this is a big number, and the government and the insurance companies, they all know how important it is to treat those patients or to not treat them. So one thing that it is important when you start doing endovascular venous procedures, that treating the entire system is key for success. So if you decide to treat an occluded vein and you don't pay attention to the entire system, to the whole thing, you are in a great risk of unsuccessful procedure. Sorry. So based on DVT location, I would say that treating the entire system is important when you have a tibial or under the knee occlusions, a popliteal occlusion, and in combination with more proximal lesions. So if you decide to treat a patient that has a popliteal occlusion or under the knee infrapopliteal occlusions, just the femoral occlusion or just the proximal occlusion, you won't get inflow, and these are the stents that will close down in a few months. So remember that you must treat the entire system. And why do I say that? Because let me use what we do want when we're doing this kind of procedures is to get flow. So key, flow, and how come that we get that flow? There's this mathematical function that will show us that you need a pressure difference, you need a radius, you do need to treat the length of your occlusion, and you need to pay attention to the viscosity of blood that you're treating. So for this presentation that we are specifically talking about flow-directed lysis, I want you to pay attention that in here we have the inflow volume that is connected, directly connected to calf function. Sorry, I just need to get back. So if you don't give this inflow volume with open veins down there, you are in high risk to have your stents closed. So what I'm here to defend is that when you're doing a proximal recanalization or a femoral recanalization, you must pay attention to these veins and be sure that whatever you get open here will help you to have a good inflow and good blood flow going through your stents and keep them open. So we always start from an occluded vein. So if you get lysis and PTA and get something like that open again, even in those small veins from the cough, from the popliteal vein, you will gain a lot of volume that will help you to have better results. So when you do have something like that, a patient with an occluded popliteal vein that in the next ultrasound is showing that the femoral vein just started to close down. If you don't treat this area, the patient will develop severe post-thrombotic syndrome. So these are the images of all these clots staying and sitting into the infrapopliteal veins. And if you don't get rid of them, the proximal reconstruction won't work. So what we do is that we study the entire system. As I said, you have to treat everything, especially the infrapopliteal veins, so you can decide what to do. What we do is the flow-directed technique in combination with proximal catheter directed lysis or pharmacomechanical lysis will help you to have an entire open system, an entire venous system flow, helping you to get a better result. So what we do is a puncture in a pedal vein, and sometimes because these are patients with high edema, you need some help to get to that vein. It's not going. I don't know why. I am doing. No. And also, we do have these tourniquets that Dr. Tharp developed over the years that help you to push the drugs into the deep system, redirect the drugs from the superficial veins to the deep system, and that will help the drugs, an optimal amount of drug to be in contact with the clots, and then you get recanalization. So this is how it looks like after you got the pedal puncture access and the tourniquet located here to close the saphenous vein and direct the drug to the deep system. Another patient, another view of that. How it looks like when you are doing catheter-directed lysis and flow-directed lysis with the tourniquets located to close the saphenous vein here and here. So everything will go to the deep system. Sometimes we do use compression systems to help the drug to mix with clots in the calf and have a better result. So what you get is, at the beginning, you have a lot of clot sitting there in the popliteal vein and the tibial veins. And then after you do 24 hours of lytic therapy, what you get is an open popliteal vein and everything. And if you do all the areas that you reintroduced into the system here, these are the areas of venous, of blood flow that will keep all the proximal stents opened. So this is a patient that we did last week that had a closed popliteal vein, and after doing the flow-directed lytic therapy, the intravascular ultrasound would show an open popliteal vein, and I'll show you what happened. This is pre-procedure that he came. He had 11 years of DVT and this open ulcer that he tried to treat for these 11 years with combining skin, implants, and all kinds of como é que fala? Curativo, of dressings that you can imagine. And this is 1 month after the procedure that you can see the difference and why we do defend this flow-directed therapy in order to give these guys an open venous system below the knee and help them to have a proximal open system. Another case, and you can see that it's all closed, and after 24 hours or 36 hours of lytic therapy, you just get a lot of new veins coming and a lot of new blood flow helping us to keep proximal lesions opened. Yeah, and also this one, another example of how much do you get after doing this technique and helping these patients to have better results. So why do we do this in combination with catheter-directed lysis? Because we get a lot better early angiographic and hemodynamic success rate. So you will see through your angiograms that the blood flow going in through the stents and through everything that you treated are a lot better than not doing that. And also, when we do this kind of procedure with patients with more proximal lesions, what we do find is that the long-term stent patents are improved. But the more important than all of that is that these patients will get a lot better clinical improvement is important. Those guys are the ones that would have venous claudication, and it's just gone after procedures. And all the signs and symptoms of chronic venous insufficiency are a lot better than before the procedure, which helps them to improve their quality of life. So I do defend that when you decide to do a venous procedure, an endovascular recanalization that is proximal from the femoral vein through the iliac veins and inferior vena cava, always consider to combine this to help you to have a better inflow and to prevent early venous occlusions. Thank you.
Could we go back a slide here? Can I reverse it back? You're fine. Well, thank you very much. Dr. Ossie and I worked together at the University of Iowa, and I was able to share this, and Dr. Hunter, who's here too, also kindly referred to this as a Thorpe technique. But I was frustrated because when we started treating DVT in the late 80s with catheters, early 90s, there was no way to get catheters into all these veins. And there are 100 valves below the knee, maybe 7 above the knee. And if those gastrocnemius and deeper system veins are occluded, the calf muscle pump is rendered useless, or it really hurts the patient's legs. So we're trying to reduce the resistance to flow when the muscle pumps. And I just want to point out this case. This is a chronic case. This is not an acute case. The other one was acute. This is quite chronic. There are a lot of patients who don't have DVT until after they have knee surgery. And Joe had DVT after hip surgery. But after knee surgery, the successful knee surgery then translates, if you get DVT, into a really bad clinical outcome because their leg is worse than it was before. This man was about ready to lose his pension because he had exhausted his sick leave. He had been working at a place for nearly 39 years, 40 years. He only had 2 years to go before he could retire. And the physician sent him to me sort of out of desperation, said, you know, you do this DVT work, can you help this man? And I said, well, you know what I have to offer you is my method of treating. I mostly have done acute, but I'll try chronic, and we'll see if it helps you, because I can drive at the time urokinase into the deep system, and we'll see. So his avocation outside of working as a stevedore on the docks was he was in masters wrestling. He was in very fit shape, and he was just in tears that he thought he was going to lose his job because he couldn't go to work anymore and keep up with the guys. So 72 hours of tourniquet-driven urokinase into the deep venous system, very low complication, no complications, a pedal infusion, and the results are evident that you can see that the opening up of these veins is not perfect, but it was enough for his leg to feel normal. He wore stocking, but he just was so happy that the pain went away and he could walk, and his life came back to normal because he wasn't always complaining about his leg. And I remember him very well because when he came back to the clinic to thank me, he squeezed me so hard because he was this semi-professional wrestler. But he was so happy that we fixed his leg. And I know of no other way to fix this man's leg, even with 20 more years of experience, than to use the tourniquets like this or with the compression devices to drive the lytic agent. So it's impressive what the results can be. It's low tech, but it really makes sense. And so we wanted to share this technique with you today. Dr. Hunter.
Just looking at your pictures, the only times that I've used this technique, which I actually use more often than not for DVTs that go all the way down to the ankle level. I've used the posterior tibial vein because it's easy to get into as my primary source for the infusion. Do you think there's any benefit to using the vein on the dorsal of the foot like you were showing?
No, probably not, but you redirect the flow from through the collaterals, through Cockett's perforator into the deep venous system. So I think that it probably maybe more evenly distributes it, but if you use the posterior tibial vein, there are an awful lot of connections between all of the veins, particularly if you put the tourniquet on at the knee and keep it in the calf as long as possible. But it could just mostly divert most of your lytic agent right through the posterior tibial system and not, I don't know how widely it distributes it through the rest of the calf.
When we put in the sheath of the posterior tibial vein, we always put the tourniquet above the tip of the sheath.
Oh, so it's backflows it.
Yeah, we do it under the coil.
Uh-huh. Sure.
It doesn't have anywhere to go. But the reason I continue to use that is the biggest veins in the calf are the posterior tibial. And you always get at least both of those, and you get very rapid communication with the perineal veins, which obviously are the second largest. The anterior veins frequently aren't, even thrombosed, even in cases of bad DVT below the calf, below the knee. I was curious if you felt like you were getting the thing that we're shooting for, like you were shooting for, in addition to getting the posterior tibial and the perineal veins open, is to get the sural veins open.
Mm-hmm.
And we seem to get fairly good spread from the posterior tibial circulation into the intramuscular veins somehow. And I don't know how it gets in there, because normally, obviously, it would sort of come the other way.
Well, when you there are hundreds of transverse veins that connect the whole system. It's pretty impressive when you do the late phase arteriogram, seeing it just without pushing it from below. It's pretty impressive how much real estate is there. There's only one thing, and you probably have checked this, but posterior tibial veins can be traumatized by catheters. Have they ever thrombosed on you, or when you come back and check them, are they still open?
We've done very little chronic stuff like this.
Uh-huh.
But with acute clot,
Well, it's certainly a good way to get directly to the popliteal if that's your actual problem. So, yeah. Well, you know, the reason why I've stayed with the pedal infusion is I didn't want to traumatize the posterior tibias because I know how important they are. So maybe I've been erring on the side of caution. But thanks for saying that. All right. Well, we have an excellent panel about wound care, which is important to all of us. And today, Dr. Jenkins is sitting back there. Do you want to come up for us? Yes, no, Dr. Grady. But I just want to introduce the panel. These people are well known in their field of podiatry. They're physicians of podiatry medicine. And it's Dr. Garofalus, right here, Dr. Grady, who's well known to people in this area, and Dr. Desmond Bell, who will be coming up here, and Dr. Jenkins, John Dale Jenkins, also from the Chicago area. So thank you very much. This is a good panel of people who are very knowledgeable about wound care, and I'm going to ask Dr. Grady to give the talk that he didn't talk late in the morning, and he's going to start with that and continue with his second talk. The first talk is the one about, not the anatomy of a wound clinic, but the first one about
Thanks.
advances,
Dr. Thorpe.
right, thanks.
Yeah, thank you. Naturally, these microphones don't go up high enough, Dave, for some of us. You know, what I did during the break was sort of combine these two talks. I'm not going to keep you so long. I sort of combined them, squished them together, took some things out of one so that they would flow. And I think it'll give you the idea. You know, when I was asked to do this talk, Anatomy of a Wound Clinic, and by the way, if Dr. Ossi has to apologize for his English, then I need to apologize for my English. The difference is he at least has a good Portuguese to fall back on, and I don't. So I'd like to preempt that and say I'm apologizing for my English today, because that's usually where I get into trouble. But, you know, when I was given this topic, I really thought, you know, the typical way I would take this on would be to take the specialists, make a flow chart, and roll that through what you do when with each specialist. But that'd be nuts with this audience. You know where everybody fits in. And that's not the way I want to take this, really. I want to take this a different way to let you know what needs to be provided and what I think it'll come to in the future as far as what a wound clinic's going to look like. And in the course of this, I'm going to squeeze in my venous ulcer treatment modality talk. And of course, if you're a Chicago sports fan like I am, you only have one picture you could possibly put up anymore, with only one sport being the thing you want to emphasize. Yeah, everybody today, everybody harps on the way diabetes is growing. And you know, this slide is showing the projected 55% increase by 2025. Two people earlier quoted the CDC prediction that in America, the population of diabetics is going to double by 2030. It's tremendously advancing, and I love the term diabesity for the way this is advancing. Obesity is advancing at the same rate as diabetes, and those two are interrelated somewhat. So we have a big mission happening in front of us, and there's no doubt everybody also focuses on how costly it is with the incidence of ulcers growing, the lifetime risk growing, and where you end up with on the amputation spectrum when you have diabetes or PAD or neuropathy. So most people, although they understand how miserable the disease is and how miserable the ulcers are, I got to tell you, our track record in treating them is miserable as well. And I mean it's across the board with physicians treating ulcers. This is Margolis' study showing 20-week endpoint of ulcers at best was almost 31%. And you know, it's just not good enough. And if you look at cost, this is 1996 data, by the way, I put up here because I had such a great data study for insurance companies. And here's what insurance companies used to blast me with in the 90s. They blasted me with, everybody does one amputation, then the other amputation, then the other amputation, then the other amputation. We are spending $50,000 before we get to the third amputation. And now, of course, it's $79,000 per amputation, by the way, for the perioperative course instead of $54,000. And the individual amputations still are equal. So for an insurance company to give up front, let's just do a below-the-knee amputation. That was their attitude in the 90s. Let's just do a below-the-knee amputation. Why would you save a leg? Well, I'll tell you why you save a leg. Because now, and so I got data together to show them why they could save a leg and what it would cost them in the long run if they didn't. So here's what it amounts to. This is from Giannini's Deaconess study where he put together costs. These costs are strictly medical costs, not loss of income from loss of job or anything like that. It's just strictly medical cost. And this is a combination of private and Medicare patients that were combined with the population that he was looking at, which accounts to 13% Medicare patients in the population he looked at. So in that population, I just want you to know, digital amputations definitely win. And TMAs definitely win. And SIMEs, tough procedure with a third failure rate, still wins. And BKAs lose, and AKAs lose more. There's a rehab, by the way, this includes secondary surgeries such as reperfusion grafting and things like that. And granted, they were very aggressive with regrafting at Deaconess, so it's a little skewed. And when you look at the population, it's a skewed, healthy population of diabetics that were getting the peripheral amps, the more peripheral amps, because they were actually healthier. So I know it's skewed a little bit, but I'm still telling you this is the data I wanted, and this is the data I used against insurance companies. By the way, it didn't work. But they did listen to me for a little while. It got me to talk to a lot of executives at Blue Cross. It got me into a lot of avenues that I wouldn't have already been into otherwise, and it did get me to save my own patients at least, where they gave me the right to do peripheral amps, where they were taken away from us in those days. So I want you to know the rehab costs are extraordinary. The redos are extraordinary as you get to higher level amputations. I know there's not a lot of patients that beg for higher level amputations. And when I ask my patients what amputation level they want, they don't say, take it off as high as you can. So, you know, it's really, if you left it up to the patients, they'd all be choosing the peripheral amps or less. But insurance companies and maybe the government are going to be choosing a little higher level as life goes on. So it's a little bit scary in this day and age. And of course, as you know, when you get to higher level amputations, you get some morbidity. And this morbidity of inefficiency in walking translates directly to increasing obesity and increasing hyperglycemia. So it doesn't bode well for the diabetic population that lifespan is going to be increased if we're going to do higher level amputations more frequently. Now I know in this conference, you're all on board with me. You're all thinking, yeah, we want to save legs. We don't want to do amputations. But I want to tell you, you know, every study, and this is, you know, Wu's study and Armstrong's study on what pathology there is that seems to be preventable, and every study, as you know, shows prevention works and that there are preventable ulcers, preventable amputations if people would have just complied along the way, if we would have recognized it along the way, or if people would have been focused into the right arena along the way. But you know what? Every wound clinic I surveyed in the mid-2000s didn't do prevention aggressively as they should have at all. Wound clinics are focused on wounds. And wound clinics are not focused on something that actually works, which is prevention. And if you want an expense ratio, look at prevention versus treating a wound, and you'll be shocked. So the truth is, we changed this in the VA system that I work in. And we changed it to this PAVE program, which stands for Prevention of Amputations for Veterans Everywhere. And really, it's been extraordinarily successful, and it is totally focused on prevention. So they identify high-risk patients. You know who the high-risk patients are, but you don't really put it down in paper the way they need to and the way we do in PAVE. Here's what they are. Anybody with neuropathy, anybody with peripheral vascular disease of any sort, venous or arterial, anybody with previous ulceration, anybody with a deformity that predisposes you to an ulceration, anybody that's had previous amputations or had, as I said, previous ulcerations, those are all people that are in that high-risk category. And when you take that population and run them through a prevention module, it works, and it works well. The trouble is there's no such animal other than in the VA system, and it's been pretty recently employed there. Following through statistically is remarkable when you do go through this, but I want to go through a different way. So my thinking on this is going to agree with Dr. Armstrong's study here. You all know that peripheral artery disease, diabetes, but especially ulcerations in that population are deadly. And you all know it corresponds to being extraordinarily more deadly than, cancer. And if you take ulcerations in the ischemic population, they're more deadly than almost very deadly cancers. So let's take a different approach to this. What works best in cancer? Screening and prevention. People are dieting for cancer. People are taking certain nutritional elements for cancer. People are definitely, in the clinical community of medical doctors, they are definitely treating cancer preventatively by doing screenings, by making sure patients are not getting it, by being aware of it. But in the diabetic community, they're not doing screenings. They're really not reacting to this. And we're really not setting this up the way it needs to be set up. We need to treat this like it is. It's worse than cancer. And there's no doubt about it. So we should treat it like we treat cancer, except more aggressively. And, so I like to call these the 6 Ps of who should be on the team. And even though there's 6 Ps and they all have distinct roles, I got to tell you, they're all one big P. They're all prevention managers. They're great preventionists if they choose to do this and if they're employed this way. So, yeah, ironically, when vascular procedures and interventional procedures are employed early, do you get better results when they're employed early than when they're employed late? Yeah. That's universal. So we need to screen for these people earlier and be doing more of these procedures earlier. Unfortunately, you get criticized, especially when you have a new procedure like many of you have, and and you're taking on the tough patients that are deadly already because you don't want to take on the patient that's not that deadly, and of course then your results are skewedly worse, I think. And in that approach, we're not doing as much good as we could. Certainly, when you offload early, when you have an identified deformity, you get a great result. All these people are excellent preventionists. They're just not employed as preventionists very often. And then I wanted to, because I knew I was going to be here with the APMA president, Dr. Garofalus, I wanted to give him credit for this great article in Thomson Reuters study on the economic value of specialized lower extremity medical care by podiatric physicians. And I wanted to tell you the statistics on, which you already, most of you know, but the statistics on what it means to add podiatric care to a given population. And what it means is, and this is to an ulcer-driven population, not a prevention population where you could do a lot better. In the ulcer-driven population, the cost of treating ulcers in diabetics in private pay patients is an average saving per patient of $13,700 in private patients. In Medicare patients, $3,000 some dollars. And this equates to a 1% net improvement, which means if you put 1% more, if you put for each 1% of patients you put into the system, private insurance would save, is it 12.7? Private insurance would save $17,474,000, and Medicare would save 12.7. Yeah, 12.7. So, the difference is phenomenal when you actually get to the amount you could be saving by increasing the money. Where are you going to increase the money? Prevention. Where do you think the government's thinking of increasing money? Not prevention. They're not thinking of increasing money, let me tell you. But if you threw dollars into this system preventatively, it would pay off. And it would pay off remarkably well, remarkably quickly. But they're not going to I don't think that's the plan, to throw dollars into the system. So, and if you look at this, I'm going to bring you into my world for a minute, those of you who aren't in my world. And this is the world I live in. Reps come into my office and they say, hey, look at this great new product we have, wound care-wise, and this is what it is. And they show me these case studies where it looks to me like that ulcer would have healed no matter what they put on it or didn't put on it. And I say to them, gee, this doesn't look like I can necessarily believe it. Give me a bunch of studies that show what this does versus standard treatment now that I might be employing. I never get those studies back. That chases them away forever. But I am deluged with people showing me what new products they have, what works and what doesn't work. And I believe most products are 510K'd in the research department. They are not pre-market approved. They are not tested and approved before they're applied. They mimic some other product that's out there, or they test themselves against one other product that's out there, which isn't a standard treatment, and they end up getting approval as such. And it's really dangerous to start to believe that things you put on a wound are going to make it better when 20 to 30% of them are probably inappropriate, probably even higher than that. When you look through what needs to be assessed in the prevention model, we all fit in really well to that. But it also needs to be corrected when you find something wrong along the way before they develop the ulcer. And when you start to employ wound care in advance of wounds, you'll get really good results. Doing revascular procedure early on, doing accommodation for wounds early on, doing corrective procedures for deformities early on, really good results. And despite the fact that wound care, once wounds develop, is good, still wounds heal poorly and when they're already there. So I'd like to say, in general, it's certainly not what you put on a wound, it's what you take off a wound that's going to make it heal once the wound is there. There's no doubt about it. There's no magic pill. There's nothing you're going to do that's going to put on the wound what it needs to heal. It's what you take off. Take off the plaque and let the artery work. Take off the venous congestion. Take off the debris. Take off the infection. It is not putting on things that's going to make a wound heal. And I can't think of many exceptions to that. Certainly some grafts work sometimes. So I want to also go through the fact that, Sheehan did this great study that shows that in the venous world, this is a little different, so I'll tell you about that in a second. But in the arterial world, and in neuropathic ulcers in particular, if they don't decrease in size by half within 4 weeks, they are largely not going to heal. And you can see that on this graph, and you can see it on the next graph too. And there is even, and you can rate that. I used to look at wounds, and they'd be healing, well, in 2 weeks you've gotten 2 millimeters of improvement for a 6 centimeter wound. I see, at least you're improving. But now I know, if it's not healed in 4 weeks, if it's not half healed in 4 weeks, it's not going to heal. If it's open too long, it becomes more of a nightmare. Is there any argument that the ulcer that's open longer or exists longer is more difficult for numerous reasons? And that you have to go back to the assessment model and figure out what's keeping it from healing. Is it vascularly impaired? Is it that they don't comply? Is it that they have bacterial overload? Is it that there's something to debride that I didn't debride? Or is there some deformity that I'm not compensating for that's still there? There's got to be something you reassess if it's in that situation where it's not getting better at that rate. And it clearly, your care will be given in a better sense if you do that. So I want a disclosure here. I'm going to present some products, but just happen to be things I had in the office. And so they aren't things that I endorse at all, not paid by anybody for anything. So I can say anything I want. I think these are just examples of certain types. So everybody used to, and I did research on platelet-derived growth factor for 9 years. And a lot of it was platelet release aid, and it just didn't work. And I'll show you why in a few minutes. But for now, I'm going to tell you that, a lot of things today we throw on wounds. Platelet-rich plasma, and sometimes it works. But I got to tell you, when you test platelet-rich plasma against placebo, it's not great. Hyperbaric oxygen, when you use it against placebo, which really is hyperbaric chamber with air rather than hyperbaric oxygen, not doing the studies that have been done like hyperbaric against saline and things like that, because when they're off their foot, when they're in their chamber, it's a different organism of treating rather than when they're on it and things like that. So, there's a lot of differences when you're using hyperbaric versus something else versus a placebo hyperbaric. But when you start to test those things, it just doesn't test out well. And there certainly are some exceptions. Anaerobic infection, there's certainly things. And changing the environment sometimes is a great thing. And doing hyperbaric placebo-driven is still good because it works 30% of the time as a placebo, so nothing wrong with that. Again, it's not what you put on wounds, but once you have a very good granulating wound, these products that actually were pre-market approved, well-researched before they came to market, actually do work. And you know, Berkepleman is here in the screen. You know, when I did research on platelet releaseate, and I did research on platelet-derived growth factor later that we divvied up into the 7 components of platelet-derived growth factor, but when I was doing that, it wasn't beating placebo. And when it was your own platelets that were taken out, spun down, and put on, that was not working at all. Placebo worked just as good. But when we started to realize it's the diabetics' platelets that are deficient, and that's the trouble. You're putting his own back on. That doesn't work. Doesn't work well at all. So other things I want you to know about, just to give you the pearl things that you know all about management of arterial disease and the wound environment and infection control and offloading and hyperbaric and advanced therapies. But I always like to harp on the anti-granulogenic and anti-angiogenic drugs. So many of my patients are on concurrent drugs that inhibit their wound healing. Those drugs are antihypertensives, antimetabolites, anti-inflammatory agents. So many of my patients have comorbidities, arthritis, coronary artery disease. And so those things keep your wounds from healing. You've got to change their medication role sometime when you're dealing with these patients. And then since I'm intermingling a lot of the stasis talk, I wanted to tell you that a lot of things we use for stasis when we're early on and just studying what worked and what doesn't work, you know, were kind of funny. There were support hose, intermittent compression, and then 4-layer compression started to come into this play. And you know, when you use those things independently, they don't really work well. But when you use them in conjunction, they sort of do. But there's a dilemma in using compression. The dilemma is a lot of those patients with the more severe venous stasis problems have the more severe CHF. And because they're in heart failure, you can't overload the fluid, and so you can't compress. And then a lot of them have arterial disease. And if your Dopplers aren't 0.7 or above, you really shouldn't be compressing those arteries. So the trouble is, you're limited by who you can use these therapies for to the less aggressive diseased patients. So, you know, we got into trouble because we sort of stretched these things. You've got to really treat the CHF. You've got to use things that don't cause the problems that compression can cause when you treat these ulcers. So it gets a little difficult, but the best way to use 4-layer compression is actually with intermittent compression. Use intermittent compression first, use the 4-layer compression after. If you have to do that daily, that's a great technique. It's not convenient for a lot of people. It's not cost effective for a lot of people. Works well in the hospital, doesn't work well on an outpatient basis. Works well in a nursing home too. Support hose is controversial. We did a study 17 years ago on support hose compliance. At the time, 13% of our patients were complying with support hose. So I don't think it's changed in my lifetime. I really think support hose is just something people don't use. When they use it wrong. The support hose people that dispense them don't necessarily measure them correctly, whether that's therapists, clerks, nurses. I get problems from all of them. There are people who are good, but a majority of people who do that just aren't great at it. It takes a lot of skill to be measuring those things. It takes a lot of skill to be wearing them. It takes a lot of commitment on a patient's part to use them. And so many of these people have difficulties putting them on. So a lot of times I can't take the pressure off by compressing it. So I try to take the pressure off by sucking it out. And that's a very valid use of negative pressure. So you can't always put compression on. You can, sometimes diurese these people and get rid of the fluid. Sometimes you can just wound vac them and get rid of the fluid. So that's another valid use of a wound vac. Modalities that I talked about, hyperbaric, but there's other things. There's different ways of debriding. I'm not arguing points of debridement. Debridement is easy, and debridement has its place. And no matter which method you use, there's different reasons why I use one or the other, but they all have a place. Oxygen delivery, though, hasn't been proven to be the same as hyperbaric in local delivery systems yet. And I want to talk about debridement. Certainly in this case, you've got a reason to debride. You got a guy who sent to me by his family practitioner with what he calls a callus. And it isn't a callus. It's an ulcer. Whenever you see purple discoloration, there's bleeding underneath. So I debride it, and there's full of pus. And this guy's got actually osteo of his second metatarsal. And so debridement has its place, there's no doubt. And this is a perfect reason to debride. But debridement has its misuses too. There are things you can't debride. So I know sometimes this is sent to me for debridement. This is pyoderma gangrenosa. If I debride this, this is a lot worse. This is an ischemic ulcer, of course, you're not going to debride that. He's got not enough flow to heal. And if I take that cap off, I've compromised what is left. And this is squamous cell carcinoma. At one point, in the veteran population that we serve, 1.5% of the stasis ulcers we'd seen that had been existing for longer than 6 months had squamous cell carcinoma biopsied later. So it's not that high anymore. We do better screening on squamous cell carcinoma. And then this is, one that actually needed to be debrided. If you take, this is my case study for stasis ulcers that I wanted to put in because it gives a good example, and I've cut out a lot of the case studies just for brevity's sake. But this is a carpenter who came to me who had retired 8 years ago. He's been treating this ulcer for 8 years. This ulcer is about 17 centimeters by 9.5 centimeters. And this ulcer he'd been treating, I got his records, he'd spent over $760,000 treating this. His insurance company did. He was retired from carpentry for the past 8 years. He used compression therapies, including intermittent compression and support hose. He used in the course of that money spent, he'd had 11 grafts from his own skin and 17 bioengineered grafts done. In addition to that, by the way, none of these ever made his ulcer better. And he said everything he's ever had done made it worse. So he came to me with this history, and he'd been to Cleveland Clinic, and he'd been to a lot of pretty good places. I mean, he didn't always follow through in the best way, I think, but he was doing the best he could in trying to get this healed. And he came to me, and I really thought, how it is. I don't know, squamous cell carcinoma? No, he had dozens of biopsies, frankly, over the years. Okay, I went through everything, the checklist. Have you tried this? Have you tried this? Everything's yes. I said, I'm going to try what I always do with venous stasis ulcers. I'm going to use intermittent compression and 4-layer compression. So in the morning, you're going to have intermittent compression, then you're going to put a 4-layer compression on. That's all I'm going to do. So this is it 3 months later. So 4 months later, he's back to work. This is 8 years ago. He's never missed a day of work since. He was 54 when I met him. He's retiring next year. So I'm just saying, it's not that hard to manage when you do some pretty simple things in some of these cases, but this is a slide I have to show you because it goes to point out what I said earlier about the difference between treating a diabetic with his own platelet-derived growth factor and somebody else's, like recombinant growth factor, like zinbercaplamine. So when you take this is from my friend, Dr. Jonathan Mansbridge, the PhD from Florida at the time, who this is a great thing. I just think this is the greatest thing. So this is a picture of fibroblast migration in an acutely cut